Thank you to everyone joining us today for our first in our Ethics Grand Round series of the 25-26 academic year. My name is Jennifer Needle Suarez, and I am a faculty member in the Center for Bioethics. For those of you joining us for the first time, the Ethics Grand Round series focuses on the intersection of ethics and health policy. We feature local, regional, and national leaders on topics in ethics and health equity. I will quickly go through some housekeeping so that we can begin with Dr. Gollust. So please use the Q&A function to ask your questions and let the center staff know if you're having any technical difficulties with the presentation. This presentation will be recorded and will be on the YouTube page for the Center for Bioethics. We have enabled captioning for this as needed. And there are 3 ways to access the evaluation after the presentation. So it will pop up on the web browser at the end of the talk. The presentation details document that has been entered into the chat will also have a link to the evaluation. You will also receive an email after the event today. If you are looking for credit of a certificate of attendance, there will be a form in the presentation details document. For Minnesota students looking for IPE credit, you will also have a reflection form in the presentation details document that you must complete, as well as biomedical engineering students. You will have the attendance quiz, and you must attend 75% of the webinar to receive credit. Thank you to our long list of co-sponsors. I will just allow everyone to see them. I have the incredible pleasure of introducing Sarah Gollust, who is a professor in the Division of Health Policy Management in the School of Public Health at the University of Minnesota. She's also an affiliate faculty member in the University of Minnesota Center for Bioethics, as well as the Center for Study of Political Psychology and the Hubbard School of Journalism and Mass Communications. Also, Dr. Gollust is the editor of the Journal of Health, Politics, Policy, and the Law. Without any further ado, I am happy to turn it over to Dr. Gollust and look forward to this presentation.
Great. Well, thank you so much for that introduction. I'm going to be speaking to you today about public perceptions of health equity and the role of communication. And as I get started, I just want to acknowledge that support for all the research studies I'll be presenting today came from the Robert Wood Johnson Foundation. Very grateful for the foundation's support. And the views expressed here do not necessarily reflect the views of the foundation. And I have no conflicts of interest to disclose. So I just want to give you a little bit of a roadmap for what we're going to do in the next 45 minutes. I will start by telling you a little bit about my research approach to understanding the role of communication and health equity and their intersection. And then I'll go through 3 different types of projects. The first is a spotlight on some of my public opinion research on awareness of health disparities or health inequities in COVID-19. I'll move on to talk about a qualitative study we undertook to engage with communicators to understand what challenges they face in communicating about health equity in a complex and dynamic environment. And then I will present some emerging research that suggests promising practices for communication surrounding health disparities and equity-oriented policy in this quite challenging communication context. So I want to start to give you a definition of health equity. As you undoubtedly know, the constructs of health equity are debated and particularly politically contested in this moment in 2025. And so it's useful to sort of bring everyone onto the same page about what these words, which are often considered buzzwords or ambiguous, actually mean. I'm drawing here from Dr. Paula Braveman's definition from an article she published earlier this year called Health Inequalities, Disparities, and Equity, What's in a Name? Her definition is that health equity means that everyone has a fair and just opportunity to be as healthy as possible. So you can see right in that definition the ethics content of fairness and justice. The definition goes on to provide a bit of a prescription about what this means for policymaking. So the definition says this requires removing obstacles to health, such as poverty, discrimination, powerlessness, and their consequences, including lack of access to good jobs with fair pay, safe environments, quality education, housing, and healthcare. Pursuing health equity means reducing and ultimately eliminating inequalities or disparities in health and its determinants that adversely affect excluded, marginalized, or disenfranchised groups of people. So that is certainly a robust definition with a lot of moving pieces. And so with this definition in mind, I want to go on to tell you how I think about the role of communication in advancing health equity and advancing the opportunities for everyone to have good health and for dismantling the obstacles that stand in many people's way. And so the first pathway that might come to mind when you think about communication would be what I call strategic communication or the organized health campaigns like public service announcements, campaigns designed to shape behavior like uptake of vaccines or uptake of mammography screening. In parallel with that, at the mass communication level, another way communication can address health equity is through disseminating evidence-based guidelines or through advertising and marketing. A form of PSAs, but we can think of advertising and marketing as being much broader about the landscape of both healthy and unhealthy products and services. Next, we can think about media, the media environment about health and healthcare. And rather than the strategic approach of some of these marketing campaigns or public service announcement campaigns, the information in media is often what I would call incidental exposure. People might turn into the local news expecting to see a weather report, and they get a story about health or healthcare. So they're exposed to it, but that media itself wasn't designed to shift behavior or policy or understanding or beliefs. There's also abundant health information in other types of media besides the news, like entertainment media, television shows about health, for instance. And then a third form of communication to health equity that we may overlook if we're thinking about mass communication, but is still nonetheless quite important, is interpersonal communication, communication from doctor to patient, nurse to patient, or how people engage with the other social determinants of health or the social policy arenas that have an impact on health, like in social service provision or housing policy or other types of venues. But cross-cutting all of these pathways from communication to advancement of health equity is a concern that communication itself can actually produce inequality. And this is because the population differs in their capacity to engage with information, to access that information, to process the information if they even receive it, and the ability to act on it. So we can think of a history of information and evidence from tobacco control, that the mere dissemination of a public service announcement or a Surgeon General's guide that says smoking is bad for you does not mean that everyone is going to be able to be equally capable of changing behavior in response to that information. In fact, the tobacco control experience tells us that information alone, without assuring access to services, smoking cessation services, and others, can actually increase health inequalities rather than decrease it. A fourth pathway of thinking about that connection between communication and health equity is where I focus a bunch of my work, the sort of most of my research and the research that I'll be sharing with you for the rest of today. And that's what I think of as a pathway through politics, where we can think about communication about health equity and about the policies that might promote health equity as conveyed through mass communication, such as the media, both the volume of attention to these issues and the content or quality of attention. And in this pathway, the outcomes we can think of rather than an individual behavior change, such as getting a vaccine or not, are outcomes like awareness of disparities, agenda setting, how important health equity or health disparities are on the broad agenda when there are so many other issues competing for attention. What are the causes of these health inequities, the causal attributions, or who's responsible to engage in systematic policies or practices to address them? And last, individuals or mass public's engagement or mobilization around these issues. And just as I described in the other schemas for thinking about communication to health equity, there can be both intended and unintended or negative consequences of this political pathway as well. So many years ago, actually, published in 2013, my colleagues and I put together a framework for thinking about this pathway of linking communication about health equity or health disparities to these various policy related outcomes that you can see on the right side of this model. And even back then, we anticipated the idea that communicating about health equity can produce unintended outcomes, including the three you see circled here: reactance or sort of negative resistance in response to the information, the enhancement of political polarization or differences across partisan groups in how they understand the issue of disparities or support to address it, and activating stereotypes. And this is the idea that in absence of sort of information that explains what health disparities are and how they came about, information about disparities can actually activate negative stereotypes about the groups most affected by those disparities. And in turn, we predicted that thinking about this model, this could produce reduced public support or even active opposition to policies to improve health or social determinants of health. And so I tell you this model, not to say, oh, look how prescient we were back in 2013, but just to identify that sort of some of the concerns around messaging about health equity that feel very salient in today's environment have been sort of in an undercurrent in some of the work on communication and health equity for quite a long time. So, turning now to this current communication context, there's a lot of reason to believe that there is certainly more of that resistance, reactance, and polarization response that I described in that communication model in the previous slide. So, my colleagues and I have been tracking mass communication about issues of racism and health equity and its backlash for some time. And what you can see on this slide is actually our work to quantify attention to structural racism in local TV news. The way we do this is by running keyword searches of the closed captioning. Yes, the closed captioning that you might try to turn off if it's on your television and you don't need it, or turn on if you do need it. We are able to use that information as data to track mentions across TV news outlets around the country. And what you see here is an incredible spike in attention to structural racism in the middle of 2020, corresponding with the racial reckoning after George Floyd's murder here in Minneapolis. So you can see there was an enormous increase in attention. 800 news stories is the peak there that mentioned structural racism and a pretty dramatic decline thereafter. We've continued to track these issues, including concepts that are sort of more negatively attached to issues of racism and health inequities in the United States today, including critical race theory, which is often framed as against critical race theory, and anti-DEI movements. And so you can see as we've tracked it that we see this very big spike now into more attention to DEI, but less attention to structural racism, which really represents this dynamic and competitive backlash environment around health equity that we see today. So our research team is called the Collaborative on Media and Messaging for Health and Social Policy, and I lead the University of Minnesota site, but we have teams at Cornell University and Wesleyan, the Wesleyan Media Project as well. And we were founded under the assumption that we need much more and more rapid research on health and racial equity, given this dynamic communication context that I just described. We're an interdisciplinary team of researchers that span political science, communication, psychology, and health policy and public health, which is my kind of home discipline. And in the first year of our existence, we were founded with funding in 2022. We started with two major studies to try to understand the communication context around health equity that I'll tell you more about. The first tracked public opinion about disparities in COVID-19, and the second, qualitative, engaged with communicators on the ground about what their perspectives are and the challenges of communicating in this environment. I'll move now to the first study on public opinion about disparities. We published this work in 2024 with thanks to the co-authors you can see on this screen from our paper published in the Journal of Health Politics, Policy and Law. And for this work, we collected data on public opinion about mortality disparities in COVID-19 over 4 waves. In April 2020, almost immediately, or the month after COVID-19 really reached U.S. soil, and we began to see the aggressive responses in the United States to curtail its spread. We went back into the field in August 2020, then April 2021, and then April 2023, using the same set of survey items so we could track differences over time. We used a nationally representative sample from NORC called AmeriSpeak, and we had about 1,000 people in each wave, except we were able to use a larger sample in the August 2020 wave. So these are some key results from this public opinion survey measurement efforts. I know this figure can be a little bit confusing, so I just want you to focus on the size of the blue bar. And so what these data tell us is the percent of the public that agrees that there are differences in mortality based on people's chronic illness, pre-existing chronic illness, and age. And so the first set of blue bars tells us that well over 70 to 80% of Americans recognize that there were disparities by chronic illness and a similar amount by age. That is, that older Americans were more likely to die from COVID-19 and those with pre-existing conditions. We see slight declines over time. So the first bar represents the first wave of data collection in April 2020, then August 2020, then April 2021, then April 2023, but still pretty robust understanding. A credit to all the communicators and policymakers that were spreading the alarm about these differential risk factors. This next set of bars filling in the table, though, tells us a pretty different story about public perceptions of income-based and racial disparities. So it's well known from the epidemiological literature, and it was well known quite early on in the pandemic that there are grave disparities by income level and by race, with people of color and people of lower income much more likely to die from COVID-19 than those with higher incomes who are white, but the public did not recognize those to the same degree. So if you squint and you look at the blue bars on the bottom set of this figure, you can see much lower, only 50% or lower recognition of income-based and race-based disparities. And we turn now to look at differences by partisanship. So here you can see the percent of Democrats in dark blue, Republicans in red, and this is self-identified partisan identity, in those first two sets of items about whether there are disparities in chronic illness or age in COVID-19 mortality. And you can see fundamentally no differences. There's no differences in whether you're a Democrat or Republican and how much you recognize that these disparities exist across our 4 time points. These are not statistically significant, as we say. However, the pattern changes completely when we think about these two types of social disparities or social or racial disparities, where we see large and dramatic partisan differences in agreement that these disparities even exist, which much higher agreement among Democrats compared to Republicans. Turning now into our data collection in 2023, when we asked about a number of other disparities, the same pattern holds, where we see very little to limited difference by partisanship for chronic illness and age-related disparities, but wide and significant differences in how much the public recognized disparities by vaccination status, income, race, or ethnicity. For the last set of just contextual public opinion data I'll share with you today, I'll share all the percent of the public that agreed with the idea that systemic racism is a cause of health disparities. So there has been a lot of effort by public health to demonstrate that these disparities by race are not an accident, that they result from systematic differences in the environments and the legal environments and policy environments that affect people of color and Black people, particularly compared to white, and that this contributes to the disparities that we observed. In fact, the figure you see on the right demonstrates the number of resolutions and declarations that occurred spiking after 2020 and into 2021 by counties, by health departments. And I know from other work that we've done that these declarations were also communicated abundantly in the news media, linking racism as a public health crisis. And so we wanted to know in 2023, had this really sunk in? Does the public understand it? So we used the question you can see in the lower left, which came from RAND, a survey group that was also measuring perceptions of health equity and structural racism around this time, providing a definition of what systemic racism means, the policies and systems that reinforce racial discrimination and unfair treatment of some groups, and then asked how much you agree or disagree that one of the main reasons that people of color have poor health outcomes is because of systemic racism. And what we found in our data collection was overall quite low recognition of systemic racism, only 30% overall of our study. And again, that predictable now difference by partisan identity. So before I move on to the next set of results I just want to summarize what we see from public opinion in 2023. We see lower public recognition overall, that there are disparities by race and socioeconomic status in COVID-19. And this is consistent with others' work that has looked at health disparities generally, with a relatively low understanding despite the social epidemiological research, the medical research, the health research over many decades that has demonstrated these persistent disparities across different health outcomes. We also see very strong evidence of partisan differences, and this has many explanations, right? It could be that people of different political orientations are selecting different types of news media to get their information about health, which we know to be true. Perhaps those news media outlets talked less or more about health equity. This could also have to do with a political processing of information, the fact that we all filter information we hear about through our identity to assess whether that information coheres or conflicts with our own understanding of how the world works, which could in turn relate to how people respond to the survey item. They could see the item and say, I don't agree with that because of these different ways we process health messages or any types of messages. And overall, we see strong evidence of polarized perspectives on systemic racism, again, back in 2023, which has likely only expanded in the present, given the number of messages and cues in the information environment about these issues. So next we wanted to talk to communicators themselves to find out, given this context around public opinion, how are communicators talking about health equity in public health, in advocacy organizations, and other places? And the reason we wanted to do this as a research team is that we want our communication research to have an impact on the ground, on actual people who are communicating these issues every day through media, through their advocacy efforts, through serving as a communications director at, say, a state or local health department. So we wanted to know what challenges they face and what research might potentially help them or be useful to them, or that they might find that it could inform the way they do their communication practice. So we interviewed 36 communicators to understand their strategies they took around communicating about health equity, the barriers they face, and where they would find evidence to be most useful. We published this just a few months ago this year in the journal Milbank Quarterly. And again, thanking my co-authors on this work. These interviews took place again in the sort of first year of our grant. And so it was back in November 2022 to July 2023. So keep that in mind when I share the key results. We interviewed public health practitioners, leaders of both nonprofit and government agencies who do the work of public health communication. Thought leaders, these are people who are not necessarily a communication professional, but who are taking the time and effort to communicate about health equity, such as being interviewed by a news outlet. People working in advocacy organizations with a focus around health equity or social justice. And last, 8 journalists, practicing journalists across TV, digital, and print outlets who communicate about health equity as part of their kind of overall health beat. The interviews were semi-structured, took about an hour. We talked about, again, the strategies, what barriers they face, what resources or research they would want to see. We transcribed our interviews and we immediately typed up field notes summarizing the conversation. And we did that so that we could convey what we were learning as rapidly as possible back to our broader team. Because as we were learning from communicators, the pressure points they faced and what they really needed, we were also designing some research studies, which I'll share at the last third of this conversation, so that we could be as maximally responsive as we could to the real needs on the ground. We completed the rest of the qualitative analysis after this sort of rapid fire approach to analysis and completed our analysis in early 2024. So turning now to the results of these conversations, I just want to highlight this word cloud because this is from our deduce software that we used for qualitative analysis. And you can see that the size of the word represents where was the bulk of the conversation. As we coded these transcripts, where did we see the most energy or where did we spend the most time talking? And it was really around these key challenges in communication about equity. So I'll focus our attention in sharing the results with you today on that. So some challenges that we heard from our communicators were tensions around alienating audiences based on partisanship, not surprisingly, given the survey work I just shared with you. Based on residents, do we communicate differently about health equity in more urban versus more rural audiences? How explicit or less explicit should communicators be about racism and systemic racism as that, link to the crisis in public health? And how should they lead with race or other identity dimensions for which there's also great evidence of inequities in health outcomes? We also heard a lot about concern about would their messaging create backlash? Because there were studies that came about in 2021 and 2022 that were published that suggested the potential for backfire effects. The idea that if you share proactive information about health disparities, you might see your audience even move away from even less support to address them, which was a real concern among the communicators we spoke to. And they also spoke to a number of different reasons why they are seeing resistance or potential fear of resistance among their audience, including lack of understanding of key terms, like what does equity even mean? Do everyday people understand that term? The overall mistrust, not only in media, but also in public health, that has emerged and is a huge and persistent concern in this environment. Cynicism. The public just doesn't feel like there's anything that can be done was also a salient source of resistance that communicators shared with us. And this politically motivated movement against health equity, characterized again by the figure I shared at the onset of this presentation with the sort of backlash to concepts around critical race theory or DEI. So just to put a little flavor on these communicators, I want to share a few quotes to you. So the first up in the upper left, a public health leader said, sometimes I think there's tension around a focus on elevating health for people of color and American Indians, but I'm always a little worried about, if you're a poor white person who's like, what about me? Why don't you care about me? This idea that communication about health inequities could leave some audiences out. Another public health leader said, I am concerned about how do we talk about equity without talking about equity? How can we have a discussion like this without calling a thing a thing? So this concern about what words should we use? A thought leader who talked about the potential for backlash, who said, I found that it's becoming easier to be quiet and to not engage or to not speak up. I think it's because of the intensity of the backlash. And an advocate who talked about the inclination against this idea of having to hide discussing racism, who said, my entire life, I felt like this was just a sociological fact. You're denying evolution and like gravity when you're denying structural racism, right? They also shared with us some challenges about sort of the systems in which they're communicating. Institutional issues and barriers, such as journalists talking about gatekeeping by the reporters or editors, systemic racism they observed within media institutions that prevent them from communicating in the way they would like about health disparities that they're seeing in communities. Across all communicators, again, in public health, there's a scarcity of resources. They talked about resources and capacity limitations, including the access to diverse sources or public health messengers that they would want to be working with to share this information, and a sense of inconsistency or fragmentation among communicators. So, for examples of those themes, a journalist told us, when you only have 5 hours, meaning 5 hours to report a story, the only person you're probably going to talk to is a public information officer and a doctor. They're the ones who are available, or they're the ones who are going to answer the phones. But when you create a community story, you have to work on your own time. You have to get those sources a week or 2 weeks in advance. A journalist also shared with us about a back sort of resistance that they heard from their editors. Can you really say it was racism? They said. You're having to explain over again, like how racism works in healthcare. So that's how systemic racism thrives, not only within like what gets covered, the topics of covering health equity, but also in terms of how things are covered. And last, a public health leader shared this perception of a fragmented communication environment when they said public health communication happens across 3,000 different health departments instead of one field. So these 36 individuals shared a lot with us about what they need, what resources they would want to have to do better, more effective communication. They said they didn't rely much on existing messaging guides or communication research, but they were interested in that research. They wanted evidence, but they weren't always sure how to access it. They said there were that a lot of research is kept behind paywalls, and they didn't know how to get it. And they actually had a lot of desire for more resources for sharing, for trainings, for messaging resources, for a broader communication infrastructure that they could rely on. And last, they shared a number of urgent research questions, again, questions that our team has been working hard to see with our resources if we could address. So, for instance, this question of does disparity messaging lead to impact or backlash? How do we find common ground in messaging to sort of depolarize or lower the temperature around these issues of health equity? And how do we increase trust in science, in media, in public health? We heard a lot about strategies communicators were using to focus not on disparities, those negative differences in health outcomes, but thinking about assets. How do we talk about the great things that communities have that contribute to their health and well-being? What about values that are shared that we can talk about and uplift? Or what about messaging that's really centered on Black communities specifically, rather than talking about sort of other groups, but really talking about us, a community-centered approach. So just to summarize before I move on to the last section, communicators clearly had substantial challenges in their efforts to communicate about health equity from our conversations over 2022 and 2023. And they wanted research-based approaches to identify strategies that can both mobilize diverse audiences and reach resistant ones. So I'll turn now to the last section of this presentation, telling you about some evidence, some actually promising evidence about communication practices that are directly responsive to the questions, the urgent questions that we heard across these communicators. So this work comes out of 2 studies that our CommHSP team has published already, but we have several more studies in progress at varying stages of peer review that kind of add to the robust support for the themes I'll share in these 2 studies. So the first study that I'll share was led by my colleague Neil Lewis Jr., published in Social Science and Medicine earlier this year, called Beyond Fear of Backlash, Effects of Messages About Structural Drivers of COVID-19 Disparities Among Large Samples of Asian, Black, Hispanic, and White Americans. And the second study, also from our CommHSP team, led by my colleague Jeff Niederdeppy and published in PNAS Nexus also earlier this year, called Centering Historically Minoritized Populations to Design Effective Messages About an Evidence-Based Policy to Advance Social Equity. So turning now to the first study. We conducted 2 survey experiments. So this is large survey research collection in which we randomized people to engage with 2 different messages. So One group was randomly assigned to see a disparity only message. And so this would be, as an example that you see on the right, just talking about the fact that there are disparities in infections between Black and white US residents, but not spending time to explain why these are the way they are, why there are these disparities. The other messaging condition talked about structural explanations for these unequal outcomes. So as you can see the text in the yellow box, following a description of the disparity, this went on to say these differences in COVID-19 infections and deaths are due to longstanding patterns of discrimination. Historically, many of the laws and policies enacted by legislators have had the effect of limiting where Asian, Black, Indigenous, and Latino people live. As a result, they're more likely to live in densely populated neighborhoods, conditions that make it much easier for COVID-19 to spread. So rather than just asserting a disparity exists, taking time to explain why, not using a particular word or phrase like equity or racism, but really drawing out what that actually means. And what we found is actually really promising results. And so what you can see here in these two figures show in red what we're calling the intervention condition. So this is the one that used those structural explanations to explain why there are disparities compared to the gray bars, which is the quote control condition or just talking about the disparity only. And we can see that a few key themes from these figures. They're small differences, but importantly, we see that our Black, Hispanic, and Asian populations showed the deepest engagement with these health equity issues. And this is really important because we've also done some scoping reviews, some systematic reviews of the literature, and we see that a lot of studies of public opinion don't oversample for communities of color and draw their conclusions from majority white samples, which might not lead to a full understanding of how people across the population respond to information about health equity. And we did see differences by race in both policy support and advocacy intentions, but importantly, we don't see backlash or negative or aversive response to information about about the structural disparities among white samples. So we see stronger and sort of more support for COVID-19 mitigation and addressing health disparities, particularly among respondents of color when exposed to that structural explanation, but not backlash among the white respondents in our sample. The second study we designed again to be responsive to what we learned from the communicators. And in this study, rather than communicating about a disparity itself, as in the COVID-19 disparities, we were aiming to communicate about a policy that has evidence in the way it advances health equity. So going back to that original schema I told you in my sort of understanding of how we think about communicating health equity, this is communicating about a policy so that that can advance health equity so we can understand how people respond in their policy support or their willingness to say contact legislators to say to support this. And the case in question here was the child tax credit, which was initiated at the federal level in 2021 and showed incredible evidence that when you give families more resources, you can reduce child poverty. And so for this study, we designed three different groups, fielded the study among a large sample, again with over samples of respondents of color. We fielded the study in late 2023. And we had three conditions of note. The first you can see on the left, we call the control condition. It described a child tax credit and gave a call to action saying you should really, support an extension of this child tax credit, which had expired. You can contact your state and federal legislators. And then we had a universalist condition. And in this condition, we talked about how we first talked about the importance of, we used a values statement to really try to connect with all respondents. And so this version used a value statement that said, well, every child deserves the opportunity to pursue their dreams. Not all people in poverty are not able to do so, and that this country was founded on the principle that everyone should get a fair chance to succeed. So after describing those values, those shared values, we then described the policy efficacy or how well the child tax credit federal policy worked to bring children out of poverty. And in the universalist condition, we talked about that this policy benefited all children. And in the targeted universalist condition, we used the similar language as I just described for universalist, but we said not only was the child tax credit expansion in 2021 highly effective in reducing child poverty for everyone, its effects were even larger for Black and Hispanic children. And so, again, the point of this study was to understand when you talk about the targeted benefits of policy, does that boost public support for these policies, or does it promote some kind of concern around backlash? So the take home here, I've given it away in the title, is we did not see backlash of any kind by partisanship or by race to these descriptions of these equity benefits. So both the universalist and targeted universalist messages produced increased support and intentions to act, intentions to contact a policymaker among Black and Hispanic respondents. The universalist condition produced increased support among white respondents, and we did not see any of the feared sort of backlash or reduction in support or intentions to act among white or Republican respondents. And I just want to add that we have now, in the spring of 2025, our team has been replicating this approach using two different policy topics, including cuts to Medicaid, which is, of course, a really important equity issue in the context of 2025. And we're seeing that these findings do appear to replicate. So just to conclude then, I want to summarize what we've learned from these promising communication practices. The first is that the addition, as we did in this targeted universalist and universalist experiment around the child tax credit, that adding language about broadly shared values seems to help produce a more sort of common ground understanding. And we've seen this in other research too. We also suggest that explaining core concepts is critical. Relying on shortcuts, as we may do, as I do in public health communication and with my public health colleagues talking about equity, talking about systemic racism, that means really specific and important things within public health, within health and medicine, but they may not serve us well when communicating to the broader public. However, our research suggests that when you take the time to explain why the sort of deep causal mechanisms that we see in unequal outcomes, those explanations do seem to resonate. And this leads to the suggestion that, allowing disparities data to speak for itself is not always a good strategy. It can lead people to fill in the gaps. Why do we have these disparities? Maybe people will rely on stereotypes or schemas or heuristics that may not be scientifically accurate or produce common understanding or support for policies to address these disparities. And last, it seems from our work across these studies and others that really emphasizing solutions and how those policies actually work, how they work to be effective, has important value. And so with that, I know we're just about 15 minutes to the end of the presentation. So I want to first refer you to our team's website, again, acknowledging Robert Wood Johnson Foundation support for the Collaborative on Media and Messaging for Health and Social Policy. So with this link, you can get access our website, our social media, and even subscribe to learn more about this work. So thank you so much. I'm looking forward to the discussion.
Thank you so much, Sarah. And that was a wonderful way to end with positive notes. I want to ask you, because there were a couple of comments in the chat of a similar vein. I'm going to
Okay.
read you just this question, but
Would you like me to unshare or keep this slide up? Do you
you
have a
can move
preference?
up so people can grab the QR code if
Okay,
you
great.
need it. So there have been a number of comments, questions about kind of mandated language
Mm,
changing with regard to equity
yeah,
and some of the difficulties that that's creating for people in their work.
yeah.
Um, someone said that they were asked to revise their organizational plans, including their mission and vision,
Mm,
because they used words like health equity, disparities, vulnerable, and social justice.
mm,
And that it's really concerning to them with regard to, not necessarily messaging their actual principles.
Yep.
Um, and whether or not you can comment on that. Do you have ideas about resources for people that are in this similar vein, trying to communicate effectively without being able to use to
Yeah.
without calling a thing a thing?
A thing, right? Yeah. No, I mean, and that was again is a concern we heard, not just in 2025, but back when we did the interviews when thinking about how do you communicate using words that aren't buzzwords or aren't not just buzzwords that people don't understand, but also words that have been politically targeted as kind of no words. And so I absolutely share the commentators' sort of concern about doing this, and I think um, there have been some resources that have um, been put out of thinking about this, and so within the landing page for this event, I shared not only the publications that I talked about, but also two resources that have come out around communicating about health equity from an organization called the Frameworks Institute, which I think is quite valuable. So I would refer um, listeners, viewers today to those resources. I also think that that the research that we did suggested that issues, when you talk about kind of equal opportunity and fairness, that type of language is well understood and well heard by the audiences in some of our survey work, which suggests that that can be a promising way to talk about, fair access to services, fair access to health. Is a way of communicating a health equity value, but maybe using language that is both, well understood by a target audience. But again, really share it's really hard. It's really hard to communicate um, in the current context. And the frameworks folks have talked about the value of human dignity being also a resonant way of talking about um, you know what we want to owe communities in the work that we're doing. And so I've seen a lot of chatter, both among researchers, health communication scientists like myself and our team, but also those organizations working in community with practitioners to try to find the right words. So again, take a look at those resources that I made available.
Great. Someone asked if you could comment on whether you think the early data that you presented on
Mhm.
COVID would be generalizable to other health conditions
Yeah.
that are clearly, have similar disparities to
Yeah,
COVID.
and that's a great question. And in fact, in some of the work that we did, that our team did in putting together these surveys, we did go back and review. Many research teams have studied public perceptions of under public perceptions of disparities and understanding of disparities. So, for example, the RAND research team has been studying this. There's some excellent survey work out of the University of Wisconsin, led by Stephanie Robert, and across multiple studies. There's, yeah, folks from NORC, from survey firms, from RAND. We see a pretty similar pattern, which is the twofold. The first is a relatively low level of understanding and or acceptance or agreement with any type of social disparity, whether it by income or race, where across many studies, I think I've looked at 10, 12, 15 studies, we see this sort of 50% cap in understanding across the population. And so definitely corresponds with people's attitudes about disparities in diabetes, life expectancy, infant mortality, to name three of the contexts that I've reviewed the literature on. And then that partisan polarization. So those differences I've seen. So just to date me a little, my dissertation work, I collected survey data in 2006. And in that context, we saw partisan differences and understanding of disparities around diabetes. And so, yes, I think that the COVID-19 case is similar. And in fact, we had hoped that it would be different, right? That, okay, here, finally, in 2020, with all this evidence making public health so much more visible than it had ever been before, and the disparities and the equity issues and thinking about connecting health and racism, we actually anticipated the opposite. We thought we would see rising understanding, rising growth as compared to those earlier survey efforts that I described. And that just was not the case at all. To the point that I asked my colleagues, like, can you check these data? Can you check these data? Just because we did not expect to see such low levels of recognition.
Great. Well, one question was addressing kind of whether or not the conversation within the health communications community now, given the temperature of
Yeah.
communications about particular issues, um, if there's a perspective that now we need to reassess this in a different way.
Mm.
Um, if you have thoughts about kind of messaging in our current environment.
So I heard maybe two questions in that question. One about the research, and the second about general messaging advice.
Uh, we could just focus on the second one,
Okay.
and just in general, whether there's I would assume there is a conversation in the communications community right
Yeah.
now, and whether there's any thoughts about different ways to do this in the last
Yeah.
couple of
Well,
years.
I mean, I think part of what our team has been working on and why we're doing these replications, a lot of times in science generally, you come up with a study and you say, aha, we figured it out and we're just going to go with that. But because we've seen the political context and the information environment change so rapidly, our team is sort of insistent that we see if we can replicate things even in 2025, even in late 2024, and so I think that's one reason why we are looking across cases and across time to assess whether some of these, what we're calling promising practices, the communicating about policy solutions, communicating using sort of narratives that are driven by attention to values, not just talking about, disparities rates, but giving explanations that causal understanding. And those, to me, seem to be the ingredients that are standing out. And this, again, is not just from our research team, but we've had conversations with communication practitioners across, public, nonprofit, private settings on sort of what are people doing to communicate about health equity across these different contexts. And those seem to be some of the sort of shared collective ideas of the way forward. And so we hope to continue um, to research these questions and try to disseminate to translate this work out into the field. But
Great.
for the first part of that, the research is also, as many online are likely aware, uh, the funding for this type of research is also in a more challenging environment.
Really interesting question about whether your team's explored whether public perceptions on health equity change based on the affiliation of the speaker. And they said, for
Yeah.
example, if a university professor and journalists say the same thing, do attitudes about the issue move in different ways?
Yeah, no, that's an incredibly important question, and unfortunately one that we have not addressed in these set of studies that we're working on now. But I think source matters a great deal. We know from other work or from the health communication field in general that the credibility of the messenger is key. And importantly, credibility means two things. It's not just sort of is that messenger equipped? Is that journalist or that public health expert or scientist equipped because they have a particular topical expertise on this issue, but also how essentially well liked they are, or do their interests align with mine? And so that's the second part of trust in source and credibility that really matters. And so that is important both for thinking about, any of you in the audience, if you're communicating with people, that sense of trust, but that also that sort of like warmth and sense of shared interest matters a great deal as well. So um, we don't have a specific answer to the question about kind of who's the best source here, but you know from the body of literature that trusted source really depends on yeah, a sense that that individual has my back, is looking out for me. That's a construct that really matters. And in a lot of when we think about health communication generally, the people who have that trust tend to be healthcare providers, people who are work in clinic with patients one on one. There's still a lot of trust in that relationship.
I think we have time for one more question. Susanna asked in some of the research you described in which messages convey shared values,
Mhm.
that she was wondering if responses to those messages could at least be in part attributed to self-affirmation
Yeah.
effects.
Yep.
And it, so I'll leave it. She asked if it was a part of the approach.
Yeah. Yeah, exactly. So, yes, that is some definitely in the weeds health communication, political psychology work that suggests that um, in, or- people are easily able to accept information when they see their identity affirmed. And so that's where some of this idea of starting with shared values comes from the sort of academic literature on self-affirmation, and it also comes from the sort of the communication practice in organizing practice on race class narrative, which both sort of sets of findings from both practice and research suggest that affirming people's values can create more of an openness to hear and understand what comes next.
Well, thank you so much, Dr. Gollust. This was a really engaging discussion and a lot of energy in the Q&A. And as always, we didn't have enough time for all the questions, but we really do appreciate everyone who submitted them. And for those of you attending, I just wanted to let you know about our upcoming ethics grand rounds, as well as an Unpacking Bedside Bioethics presented by Jamie Connerman Cease. So on Halloween, we will have Dr. Meredith McNamara presenting about the consequences of health policy and medical decision making. And Dr. Mara Buckbinder will present in November on moral distress and burnout after Dobbs. And then we'll have our own Dr. Kozumanel in March talking about maternity care in rural US communities. So we hope that you will continue to be able to join us throughout the year, and we'll be adding more as we go. But again, Dr. Gallus, thank you so much for this really engaging discussion. And thank you to everyone who attended. The presentation details document is in the chat for anyone who needs to access any of those resources.